Good morning, everyone. Thank you, Derek. I'm very delighted that we are all in one room, primary and secondary care, without killing each other, as on Twitter you would think that's what we are doing all day. So very welcome. I'm the warm-up act, so there's the big guns are to follow. And I'm going to talk a bit about an old friend, which is metformin. So really this is all about, is metformin still part of our armory? And then talking about the new agents. So this is just to remind you what's around, what should we do, what's happening. And then there's time to take questions. So I'm very keen to have this very interactive. Thank you. So this is just to remind you what's old and what's new. And I think it varies of what our preferences are. You will find the odd person who may like the old phone, sitting on its stairs, not being interrupted. You could just talk to one person without anything else happening. And many of us will, of course, like the other bit much more, the smartphone with everything at your fingertips. Anyone can get you, you could get anyone. And again, this is just to remind us, old and new, it's your preference, really. I don't think there's a right or wrong. This is an old coffee house. We used to love them. We sit there for hours. Now we have a coffee on the go. And again, is that better? Is that worse? We could take votes for it. And this is a picture which I am using to remind me and you, really, to show how perhaps the old and the new somehow need to be combined. This is a place called the Humboldt Forum in Berlin, where I've come from, which is the old city palace, and they made that they're trying to be as ambitious as the British Museum, trying to sort of combine old and new, and they realize there's no other way, really. Yeah, and they're having a go combining the old with the new. In 2008, my slides don't change on my screen. I don't know whether we can change that so I don't get a crick in the neck. Thank you. In 2008, if you did a word cloud of diabetes guidance, we would see you have metformin, thank you, metformin bang in the middle. You have a lot on weight gain, insulin resistance, and glycemic control. And 11 years later, the guidance has really changed and our focus has changed. And you can see there's heart failure, chronic kidney disease, the new agents, and cardiovascular endpoints. So these are word clouds. So this is literally scanning a document, seeing how often a specific word comes up. And the more often it comes up, the the bigger it is on the screen. So you can see there's quite a shift in how we treat diabetes, how we look at diabetes. So this is the most recent really consensus, both by the American Diabetes Association and by the European Association for the Study of Diabetes. And this is a rather big flow chart, and you probably have seen that, and it's so big that you really think, where do I start, what do I do? And I'm going to take this into little bite-sized pieces for you. So we start at diagnosis. The recommendation remains lifestyle, weight management, and physical activity, as well as metformin. And we used to do, I think, go away, exercise, eat healthily for 3 to 6 months, and then come back, and then we may give you a drug. And I think the guidance really very clearly, and our preference, and I suspect your way of working as well, is to say metformin plus exercise and healthy diet. That's your first step. And of course, it depends what the patient says, what their lifestyle is, whether they have comorbidities, how much time you think you have to look after them. Are they motivated? What's their background? Because there may be people who really say, I will exercise, I will lose weight, there's lots of stuff I can change. I saw a young man, maybe 3 weeks ago, who was drinking 10 bottles of Coca-Cola. And we had a long discussion, and we were both delighted about it because we thought that's a really quick win. Whether he will actually manage to stop it, and I don't know, but if he does, I suspect if we manage that, we might manage his diabetes without medication. So I think it's and I know especially in primary care, you have a very, very short time for a discussion like that. But that discussion, if you can have it, is actually really helpful to try to individualize what you do. And then there's an approach to individualization of glycemic targets. And the top 5 are non-modifiable, so your life expectancy, your comorbidities, and then the bottom 2 are A, the patient preference, and B, the environment you are in, so resources, support system. And again, if someone has a very low life expectancy, then there's very little point in aggressively treating their glycemic control. So if your HbA1c remains above target despite recommended first treatment, the guidelines don't say how soon you should check, but I would think 3 to 6 months. So if your HbA1c remains above target, whatever that target is for your patient, you should ask yourself the question, does this patient have established atherosclerotic cardiovascular disease or chronic kidney disease? And if the answer is yes, then you may, if you see this flow chart again, so this is your left side, ignore the right and the blue, the blue and the red. And so if your cardiovascular disease predominates, you would offer the patient a GLP-1 receptor agonist, ideally one which has proven benefit on cardiovascular disease. And then you would add an SGLT2 inhibitor for the same indication. If you, so this is still on your left-hand side of that flow chart, if your patient is in a situation where heart failure or chronic kidney disease predominates, you would flip it around, so you would, so an SGLT2 inhibitor with evidence of reducing heart failure or reducing kidney disease progression would be your next option. And then you go back 3 months later, 3 to 6 months, if HbA1c remains above target, and you've looked at your patient, in fact, they don't have cardiovascular disease or chronic kidney disease, you have a even bigger choice of what to do. So this is the right side of your flow chart, and you can see you would look at, does this patient, is there worries about hypoglycemia? Are they painter and decorator on a ladder? Are they a driver? Are they a young father bathing a child? So all those things, are you worried about hypoglycemia? And in fact, I had a tree surgeon earlier this year who fell off a ladder for hypoglycemia. So that's not good. So taking a history, and we often ask for driving history, but taking a professional history is really quite important. And then you have a choice of drugs to minimize hypoglycemia, and really what you would do is to, if you go to the bottom of that left yellow column, you would use sulfonylurea or insulin late in this group. Yeah, you would use anything else but sulfonylurea or insulin. And it probably doesn't almost matter which of the drugs you use, in which order, and you just keep going to get your HbA1c to target, depending on what's palatable to the patient. If you and the patient worry more about weight, so minimizing weight gain or promoting weight loss, then again, probably the newer agents, in addition to the metformin, are preferential. So you would use a GLP-1 receptor agonist, an SGLT2 inhibitor, and then add oral agents, and again, only use sulfonylurea and insulin later on. And then I have this on the right, and of course we could be optimistic and say cost is never going to be a major issue, but if you read the papers, it may well be that everything I'm telling you now will change, and these drugs, both insulin, sulfonylurea, thiazolidinediones, and insulin, are excellent at achieving good glycemic control. They don't have the evidence for everything else, but they're excellent they're working, and that may well be something, if there's going to be cost pressures, that's what we might end up returning to in certain patient groups. So, we talked about that. Sorry, and I'm actually going to... So I think this is, and I said this morning, hello to one of the speakers later on, Adrian Brown, who is going to talk about nutrition, really. And I think that's very, very, very interesting to talk to your patients about lifestyle as you go along. So as you adjust your medication, you should return to your discussion on physical activity and lifestyle, eating pattern, disordered eating, physical activity, and that really needs to be very individualized, because there's no hope otherwise. So I had an elderly lady who can't actually walk really as far as she's just managing to schlep herself in and out of my consulting room. And she came in with a leaflet which someone else had given her, one of my colleagues, which is said how to do 150 minutes of exercise every week, and this is the options. And none of these options were suitable for her at all. So it does need to be individualized and thoughtful, I think, because otherwise people get upset and will stop trusting your advice. And then I think we don't have a lot of talk about this today, but then other thoughts on medication for weight loss are important, and bariatric surgery. So if we cannot control diabetes with our medication, then these are the things to think about. Yeah. So we talked about cost. This is my pet hate, this sort of slide I hate to see, and yet I'm showing it to you. And I'm showing it to you because it's very useful, and I just want you to signpost. I don't want you to read it, which is also my pet hate when people say this, but yet I'm saying it. So this gives you all the agents, and this gives you how to choose, and it's actually very, very useful. There's a reference for the slide at the end, and I think that's quite a good thing to have on your desktop or in your drawer, whichever way you're working, because it really helps you, and you can use it with a patient. You can sort of say what's important to you, what do we want to do, and it makes you very effective clinician, really. This is just a reminder: if you have offered injectable therapies in combination with oral medication, there's no concerns about metformin with injectables. There's no concern really about SGLT2 inhibitors with injectables, apart from watching out, as you would with them in general, about diabetic ketoacidosis and sick day rules. If you have sulfonylureas, you need to just be aware that people have a higher risk of hypoglycemia, and you may need to cut down your insulin dose, or vice versa. Yeah, if I tend to stop sulfonylureas once I use basal bolus. So once I have prandial insulin or mixed insulin, I stop the sulfonylureas. I often keep them going with basal insulin. Yes, so that's that. This is so the title of my talk was really about metformin. Should we get rid of the old, in with the new? And there's very little evidence, because every person studied in the world almost is already on metformin. It's actually quite difficult to find patients for trials who aren't on metformin. So if you look at the top graph, the dots are sort of each drug, and the lines are studies which compare those drugs directly. And the top is is naive patient, so they are without metformin, and the bottom is all the trials with metformin in the background. And really this just shows you that it's actually quite difficult to give a good answer of saying should we continue to use metformin or not. We don't have the evidence one way or another. We think it's very effective, we think it's very safe, it's very cheap, so we can't really see why we shouldn't use it. But we haven't, there isn't clean data on that. And this is, again, I think just for signposting to show you changes in HbA1c. On the left is patients who are not on metformin, and you can see the GLP-1 inhibitors, receptor agonists come up top, as does insulin. And on the right, on the background of metformin, it slightly changes, but again, really, either situation is highly effective to improve glycemic control. And this is a meta-analysis looking at patients with with increased cardiovascular risk on the left and low cardiovascular risk on the right. And again, most drugs actually are very effective in any patient group. So, which brings us back to deciding what you do with anyone. Really, is very, very much depends on their and your circumstances. So, to conclude, I think, in my opinion, metformin remains the preferred initial pharmacological agent. That's also in the guidelines still, and I don't think we have any evidence to say we should change that, and I would definitely do that with my patients. I think there's early combination therapy should be considered to avoid sort of longer times in treatment failure. There's a term physician inertia, and I think that's definitely true. So we do this in blood pressure, we do this in lipids, and we do this in in glycemic control. We say, oh, come back in 3 months. The patient said, I promise I will be better. We all promise we will be better to ourselves all the time, and they haven't got any hope. So patient and physician inertia is, I think, the biggest barrier to good outcomes in this situation. I think if the HbA1c is above 10 in old money, or if patients are very symptomatic or they're losing weight, I would have a low threshold of introducing insulin. So insulin is still a very good treatment options, and patient-centered approach is a way to go. As a reminder that patients who have established cardiovascular disease or kidney disease or heart failure, the SGLT2 inhibitors or the GLP-1 receptor agonist should be recommended. And for patients with heart failure, it is the SGLT2 inhibitors who would be your first choice. And generally, the newer agents are very, very potent in lowering insulin, so that's good. As lowering glucose, so that's helpful. So they're not just excellent at other endpoints, but actually they also do what we like to see, lowering glucose. And really, you should just look every 3 to 6 months. You should see a patient. I know that's a big ask because everyone is completely swamped. But in an ideal world, I think you would make a change and see somebody at 3 months. And once they're stable, you do it for longer. And these are my 2 references. And then this is just a very simple. So if you found the big chart a bit overwhelming, then this is a simple chart. So you diagnose, you offer lifestyle, I think, with metformin at the same time. You then decide, do they have cardiovascular disease and renal disease or not? And that then decides on your treatment choice for your patient. And that's it. Thank you very much.